Welcome guys to this recall discussion of this INICET SS medicine paper, right? And it is a recall based paper. So based on the candidate who has appeared in the exam, they have recalled it. Some pattern will match, but obviously most of the question will not match to the DL exam, right? So let's start with our discussion. And before going to the discussion, just I would like to tell you, if you guys want to be part of it, we are currently going on with Harrison-based MCQ discussion series in which we are discussing Harrison in a such a fashion that completion of MCQ will lead to completion of chapter. And for this month, our target is to complete the cardinal topics from Harrison. Right? Okay. So if you want to join, you can join in this WhatsApp group. Link is available in the description. Now, coming to the question of the day. First question from the recall series. So here, a 75-year-old female with a known history of diabetes and hypertension presented emergency with complaint of increase in shortness of breath for 2 days. So SOB presentation and along with diabetes history and hypertension history. There was orthopnea, mild pedal edema, physical examination. There is bilateral basal capitation, ECG, non-specific STT changes, chest X-ray showing cardiomegaly, bilateral pulmonary venous congestion, and interstitial marking suggestive of pulmonary edema. So lab revealed NT-proBNP to be elevated, right? 953. Troponin 1 within normal limit. Which of the following is the most likely cause of the elevated NT-proBNP in this patient? So what is the diagnosis actually we are dealing with? Now, as you can see, there is symptom of orthopnea, which is nothing but left heart failure symptom. Along with there is pedal edema. Pedal edema, although classically said about right heart failure, but can also signify fluid overload. Fluid overload state in case of left atrial occlusion, right? Okay. So when does NT-proBNP increase? NT-proBNP indicates stress particular to the ventricular myocyte, which causes release of NT-proBNP into the circulation. And normal propy rules out acute coronary syndrome. Normal propy here rules out acute coronary syndrome. Now, what is the most likely cause? Most likely cause, as it is a case of left heart failure, this NT-proBNP rise should be due to the left ventricular systolic dysfunction. Now, CKD although causes rise in proBNP, but there is no need to mentioning about CKD in the question, and it causes falsely rise. And this is not so much of elevation of proBNP level in case of CKD. Pulmonary hypertension also causes rise in proBNP, but it is very much rare. Only in type 2 PAH when there is associated, which is nothing but associated with heart failure. Only in such cases, there will be rise in proBNP level. Therefore, answer is option A, left ventricular systolic dysfunction. As you can see, right heart failure symptoms are dependent edema and ascites, congestion of the liver or GI tract congestion, which results into anorexia, GI distress, and weight loss. And left heart failure, as it was given in the question, results into decrease in cardiac output. Decrease in cardiac output present with effort intolerance, which is given by NOH gradient, mainly when presentation remains at NOH 3 or 4, or pulmonary congestion. Pulmonary congestion gives the symptom of orthopnea as was present in our patient. Right? Now, even the Harrison says biomarker like NT-proBNP are used in multiple causes and it is used as an adjunctive tool for diagnosing in heart failure, particularly in walking patients who come to OPD and doesn't require extensive evaluation at point and you are confused why there is dyspnea. When you are evaluating a case of dyspnea and there is strong suspicion even after clinical history and physical examination whether it is a pulmonary cause or cardiac cause, NT-proBNP level help as a very essential tool to help identify that it is a cardiac cause of dyspnea and malaise. But important point here mentioned is that look that this NT-proBNP level may be falsely low in case of obesity, right? It can be falsely low in obesity and falsely high, it can be due to non-cardiac causes or cardiac causes. So falsely high non-cardiac causes, among which important one are like age, female, and CKD, right? And cardiac causes, apart from heart failure, where there can be high probability level, these are can be atrial fibrillation, pulmonary embolism, or pulmonary arterial hypertension, mainly due to right ventricular strain. All right. Now remember, more two important point mentioned in Harrison, which can be asked in future exam. These are galectin 3 and soluble ST2. So galectin 3 and soluble ST2 are the new biomarker which are approved for clinical utility tool for prognostication of heart failure. Right? Although it is not used widely in practice, but these are new thing, new. Okay, galectin 3 and soluble ST2. So as you can see, regarding PAH, type 2 PAH is associated with left heart disease, and type 2 PAH is the one which is associated with increase in probability level. All right. Type 1 is hereditary cause or idiopathic cause. Type 3 is due to lung disease. Similarly, type 4 is also lung disease, and type 4 is other causes, miscellaneous causes. For example, sarcoidosis is related to PAH. Okay. Let's come to our next question of the day from the recall series, which is what is the condition in which continuous murmur can be seen. Now, for definition, what is continuous murmur? Okay, so most of the guys have made mistake in this question, which I learned just. That is, what is continuous murmur? Remember, a murmur which is present in both systole and diastole. That is murmur that is here throughout the both systole and diastole without a significant gap. But that doesn't mean it should be present throughout the cardiac cycle. So this murmur can originate in this systole phase, continue till diastole, but it doesn't mean it would need to be present in the whole part of it. There's some part of the cardiac cycle can have a zone without any murmur, right? So even with continuous murmur, you can hear S1 and S2 clicks together, right? Okay. So what is the classical description of continuous murmur? We know classical description of continuous murmur we know is patent ductus arteriosus by the name machinery murmur, right? Beside this, there are other causes too. So you can remember continuous murmur as either thoracic or extrathoracic causes. Right. So thoracic causes, what are those? Thoracic causes, the number one most important one, that is PDA, asked multiple time in exam. Then any cause of atrial septal defect with increased in LA pressure. Then anomalous left coronary artery with collateral and coaction of aorta. These are the important causes of thoracic causes of continuous murmur. What are the extrathoracic causes? Extrathoracic causes you must know, that is AV fistula. Also venous thumb. Also post-pregnancy memory shuffle. Can present as continuous murmur. Right. Now, coming to this question again, let's see all the action one by one. So, how does the PDA murmur present? PDA murmur, in PDA, there is continuous flow of blood due to the presence of the patent duct connecting the pulmonary artery with this ductus arteriosus, where there is continuous ongoing flow resulting into a something we know by the name of machinery murmur. Right. It is a noisy murmur heard in the left intercostal area and also given by the name by its scientist who first described it, called known as Gibson's murmur. Right. Important additional point that you need to know regarding PDA murmur or gypsum murmur is that what kind of murmur it is? It is a continuous machinery murmur with something we call it as eddy click. What is eddy click? Eddy click is again important part for exam. So eddy click is something which occurs due to the stream of flow of pulmonary artery along with the ductus flow which collides resulting into click-like sound. So when there is this flow of ductus arteriosus and the pulmonary artery collides together, they give a click-like sound during the flow, resulting in known as some kind of click known as eddy click. Right? Now, other important question that can be asked regarding PDA murmur is that when we can't get the PDA murmur, right? When this continuous murmur is absent. It is absent, remember, if PDA is very small. Number 2 point, if PDA is very large. Number 3 point, when this PDA presents with Eisenmenger physiology, that is reversal of flow. So these are the three important causes in which PDA murmur will have absence of the continuous murmur, right? All right. Now coming to the next one, so we know PDA presents with continuous murmur. Now coming to the next pathophysiology, so here let's discuss about severe aortic regurgitation. So what happens in aortic regurgitation? Aortic valve here doesn't close properly during diastole. What should happen during diastole? During diastole, aortic valve should have closed properly so that it could have prevented the blood flow of the blood from aorta. But as the valve couldn't close properly, blood flows to the LV cavity. This backflow will cause a turbulence, producing a diastolic murmur. So, what is the pattern of it? So, this is systole, this is diastole. S2 is again divided into A2 component and P2 component. It is closure of aortic valve or pulmonary valve. Yes, aortic valve cannot flow properly. Just at the point of S2, there will be regurgitant flow, which will be very high because pressure in the aorta is very high. Pressure in the aortic pressure is very high compared to the LV pressure. LV pressure, right? So due to this high pressure gradient, the louder will be the sound at the onset of the murmur. So initially, just after A2, there will be the earth sound, followed by gradually decreasing the sound of the murmur. This is the ideal pattern of the murmur seen in aortic regurgitation known as decrescendo murmur. Right. Now, when the state is chronic, this backflow of the blood from the aorta to LV cavity will strike back to the mitral valve. And when it strikes the mitral valve, due to this regurgitant jet, mainly seen in chronic aortic regurgitation, it will form a slow pitched mid diastolic rumble, which can be best heard at the mitral region, right? So it will form a mid diastolic rumble too, which can be heard at our mitral region or apex region. And this decrescendo murmur can be heard at third and fourth intercostal space. What we call is that MS murmur, that is the functional MS murmur, which is heard in aortic regurgitation as we call it as a Austin Flint murmur. So what is the ultimate pattern of AS plus AR plus Austin Fleet murmur? Ultimate pattern of this AR plus Austin Fleet murmur is nothing but diastolic murmur. So there is no concept of systolic murmur in it. Therefore, the answer most likely will be severe AR with Austin Fleet murmur because there is no continuous murmur in this case. Now let's look into the other option so that we can obviously clearly rule out which one is correct and which one is wrong, although we know the answer is to be clear. Now coming to the first option, it is AHT with, okay, so we are coming to the fourth option. It is anomalous left coronary artery. This anomalous left coronary artery is a very rare condition, not usually seen. Now, what is the reason of this anomalous left coronary artery? Normally, it is the normal location of the origin of the left coronary artery, but here it's developed from the pulmonary artery trunk. So, as it was supposed to supply the anterior wall of the myocardium with oxygen-rich blood, but here, due to this anomalous development, there is no oxygen-rich blood at the anterior wall of myocardium, resulting into ultimately tissue death, and which presented anterior wall MI. Mainly, it is a congenital disease. So, anterior wall MI in infant is the presentation of anomalous left coronary. Now, in some cases, patient with left coronary artery develops collateral circulation, and only place from which it can develop collateral circulation is nothing but right coronary artery. So, when there is development of collateral circulation, this blood supply can be preserved, and if this blood supply can be preserved, there will be no chance of enterocolitis, or prognosis will be little bit better. Right? When this anomalous left coronary artery develops a collateral, it is the condition when there will be continuous flow of blood resulting into murmur. Right? This particular murmur is a form of a continuous murmur. Earlier, actually, they used to ask about what is the other name of anomalous left coronary artery. It is nothing but blend white garland syndrome. Right? Blend white garland syndrome. So that was the earlier days this question was used to be asked. Now they are asking about the murmur condition. Right? Okay. So we know about these three diseases. Now coming to the important one, first option, which most of you are missing, about AHD with mitral stenosis. Right? So what is the main pathophysiology here? This AHD with mitral stenosis is given by the name Luten-Becker syndrome. Right? So not actually all AHD with mitral stenosis is known as Luten-Becker syndrome. It is the congenital AHD plus rheumatic mitral stenosis, which is the current consensus to be called as Luten-Becker syndrome. All right. Okay. So what is the usual pathophysiology in it? Now, in case of atrial septal defect, it's in normal cases too, left atrial pressure is higher compared to the right atrial pressure. Blood flows from the left to right. Left to right. Now, as there is more blood flowing into the right side, RA dilates. RA blood goes to the RV, RV2 dilates. So, RA, RV dilatation is seen in case of AHD, right? And in some cases in later on develop pulmonary hypertension and features pertaining to the pulmonary hypertension. Okay, so this all alters the normal flow, increasing the volume in the right atrium, that will be the pulmonary circulation. Now, what happens when there is mitral stenosis? When this valve is stenotic, blood cannot flow through LA to LV. Obviously, naturally, pressure with LA will go very, very high. As LA pressure goes very high, there will be pulmonary congestion. And this pulmonary congestion will lead to the symptoms of left heart failure that we have discussed just now. What will the symptoms? Symptom of orthopnea, symptom of PND will increase in such patients. Right now, when there is AHD along with mitral stenosis, this symptom will not be visible because moment when there is no flow from left atrium to left ventricle, LA pressure increases before it going into the pulmonary circulation, it bypasses to the right atrium. So AHD with mitral stenosis, the severity of mitral stenosis will be low, and even in the late stage of mitral stenosis, when the whole valve is getting stenosed, the patient will be relatively asymptomatic. Okay, so patient will be relatively asymptomatic in later stages also. This is known as Luten-Baker. This condition is given by the name Luten-Baker syndrome. And as there is continuous flow of blood from left to right circulation, in this particular condition, as LA pressure increases, there will be formation of a continuous mark. All right. Okay. So answer to this question is option B, severe AR with ostensible murmur. As in AHD with mitral stenosis, there will be continuous murmur. In anomalous left coronary with collateral mainly. With collateral, we have continuous murmur. PDA will have continuous machinery murmur. It will be absent in severe AR with ostensible murmur because it is nothing but form of a diastolic murmur. Okay. So now we are moving into the next question. Okay. So which of the following is not indicated included in the diagnostic or management criteria of sarcopenia in a diabetic patient? All right. So as you can see, Harrison says clearly sarcopenia to be age-related muscle wasting. Number one point. Secondly, it says exercise is the only intervention that can prevent or even reverse the sarcopenia. Even moderate or low level of exercise, for example, 30 minutes of walking per day, have significant protective effects in obese subjects. So what we know now, sarcopenia is nothing but something to related to muscle loss, and that muscle loss is pertaining to age. Okay. So when you know this, know up to this, and also Harrison says how to treat it, only thing which can reverse it is nothing but exercise. Exercise and low level of exercise. Therefore, anyone of your family who is elderly, just advise them to walk for 30 minutes. It will be very much beneficial for them because it will help them to prevent the sarcopenia. Now, what about the other option? What are the other management things that are included in it? So, here the answer will be most likely the less carbohydrate diet. Why? Because it is not usual part of the part. So, sarcopenia management. Now, focus in management of sarcopenia should be revolve around preserving the muscle mass, right? And functional capacity of the muscle mass. Now, in any case, as the patient is diabetic, blood glucose control is going to help us and help in overall growth of the patient. Now, strengthening, already mentioned in Harrison, is the core treatment. Better is the resistant exercise stimulated muscle growth training, right? Okay, this is important. Regarding protein rich diet, muscle is composed of only protein. Muscle is composed of only protein, and it is essential for the strength of the muscle, right? Sarcopenia, and it is around 1.2 to 1.5 gram per day. Protein is required for the normal functioning of the muscle, and it prevents the muscle wasting. Regarding carbohydrates are not directly linked to muscle synthesis, unlike the protein. Secondly, overt restriction can worsen the energy available for the muscle maintenance. Even the diabetes guidelines, all the important guidelines, including the ADM, mentions balanced nutrition, balanced nutrition plus protein. giving adequate amount of protein as something which pertaining to the management of sarcopenia. So most likely answer here will be not included in the criteria is less carbohydrate diet. Okay. So we are moving to the next question now. Okay, so it is about fall in elderly. Now we have just now learned muscle weakness or something we call it to be age-related muscle weakness sarcopenia is an important part and it leads to the reduction in the strength of the body, right? So as there is reduction in strength, it will lead to impaired mobility, right? It will lead to impaired mobility and increase fall risk, number 1 point. Then arthritis or osteoarthritis type thing or any joint disease will lead to pain, joint instability. Ultimately, gait will be disturbed. And as the gait will be disturbed, there will be high chance of fall. Among the balance problem and auditory problem, what are the balance issues we know? Balance issues we know are like, for example, vestibular disease, for example, benign proximal positional vertigo. Then again, we have neuropathy, where there can be balance issues, or Parkinson's disease. All of these following conditions associated with high risk of fall. Right. But auditory problem as such is not so much common to cause fall. Therefore, answer will be the auditory problem. All right. Okay. Now, here you can see references from the Harrison as well. It mentions the usual causes of fall. You can see most commonly among the cardiovascular is arrhythmia, then neurologic is autonomic dysfunction, which present as postural hypotension. Eyesight issue can present with fall. Then benign positional vertigo, which is nothing but a balance disorder, can present as vertigo. Gait and balance disorder, gait and balance disorder can present as fall. These are the important causes of falls in case of elderly. Even the outline says, okay, so whenever you have patient with fall within last 6 months, first thing is to check for gait and balance problem. So gait disorder like Parkinson disease or balance disorder like benign paroxysmal positional vertigo should be ruled out. Even gait and balance problem will be associated with arthritis, but not with auditory problem. Now, if there is more than one fall, it asks for extensive evaluation. And evaluation, you check for visual acuity, but auditory system is usually not checked during the evaluation of fall. So, likely answer here will be auditory problem. All right. Now, moving to the next question. Okay. So here it was a large stem-based question. What does it say? Now, here an old man, 42 years old, BMI is 38 kg per meter square, presents for evaluation of persistent fatigue. So daytime sleepiness, unintentional weight gain over the past 2 years, he has history of hypertension, dyslipidemia, and impaired fasting glucose. So all comorbid conditions present. Loud snoring and episode of apnea during sleep. So this is nothing but a case of obstructive sleep apnea in a case of most likely diabetes patient, obesity patient, hyperlipidemic patient, and hypertension patient. All of those come under the syndrome complex known as metabolic syndrome, right? So ultimately, after all strategies like weight losing strategy, diet, exercise, and everything, plan is to start semaglutide. Okay, so what is semaglutide? Semaglutide is incretin secretagogue. This is a new molecule used in management of diabetes. Initially, it was available in injectable form. Currently, oral form of semaglutide is also available, and also it is approved for treatment of obesity too. Now, which of the following past medical histories is least relevant before initiating semaglutide? Remember, semaglutide is very wonderful molecule. It works by the presence of glucose in the gut, and if there is glucose present in gut, it results into secretion of insulin. So ultimately, all mechanism is done by insulin, but insulin will be only available secreted in the body when there is glucose level in the gut. So it doesn't increases the expired risks of hypoglycemia, although mechanism is done by the all action is done by the insulin. Now, as you can see here, it is a GLP-1 receptor agonist, and there are other drugs too, but semaglutide is the currently which oral formulation to available, and most importantly that it also helps in weight loss, therefore approved for treatment in obesity as well, and it doesn't cause hypoglycemia because it only acts when there is glucose in the gut, right? But important thing pertaining to it is that contraindication involves CKD or agent that also slows the GI motility because it acts on the gut, medullary carcinoma of thyroid, and pancreatic disease. Therefore, obviously from here you can see history of pancreatitis will be tough choice. If there is history of pancreatitis, you should not choose something like drug like semaglutide. Then family history of medullary thyroid carcinoma, again in such cases also semaglutide should not be chosen. Now regarding history of colorectal carcinoma, no, it is the least riskier thing till now if you are going to start semaglutide. Now regarding MEN2 symptom, so what is MEN1, MEN2 and MEN2B, right? So MEN1, MEN2A and MEN2B. These are multiple endocrine neoplasia. MEN1 goes by the name pituitary, pituitary adenoma, parathyroid, hyperplasia, and pancreatic carcinoma. These are the three disorders in MEN1, or otherwise you can remember disorder that start with P, that is 3P. So MEN1 is 3P. In MEN2, there is parathyroid hyperplasia, but there is no pancreatic carcinoma, pituitary adenoma. Rather, along with parathyroid hyperplasia, there is pheochromocytoma and medullary thyroid carcinoma. Alright, so medullary thyroid carcinoma and pheochromocytoma and parathyroid hyperplasia is present in MEN2A. So MEN2A, otherwise you can remember as 2P and 1M. 1M is medullary thyroid carcinoma. MEN2B is this medullary thyroid carcinoma, pheochromocytoma, along with other M factors. What are the other M factors? That is Marfanoid replicase or mucosal neurofibroma. So MEN2B we can remember as 1P and 2M. What is important in it? Remember, MEN2 is something which is associated with medullary thyroid cancer, and medullary thyroid cancer history is something where you do not give semaglutide. Therefore, in personal history of MEN2 syndrome also, we are going to avoid semaglutide. So, answer here among the given option is history of colorectal cancer. Alright, let's move into the next question. So, which of the following is the least common reversible cause of dementia? So, you can see very well, as given in this Harrison table, it enlists all the causes of dementia. So, all those which are marked at A, you can see these are potentially reversible causes of the dementia. Alright. So, you can see these are the most common causes of dementia. Among this, alcoholism is reversible, drug intoxication is reversible. Therefore, if question asks most common cause of reversible dementia, It is nothing but alcoholism. Right? Now look at the other causes. All the vitamin deficiencies are reversible causes. You correct the vitamin deficiencies, that dementia gets corrected. Right? Again, all the endocrine causes like thyroid disorder, adrenal insufficiency, parathyroidism, renal failure, liver failure, pulmonary failure, all of those endocrine and organ failure disorder related dementia are reversible. So all vitamin deficiencies, all endocrine diseases are reversible in nature. Now coming to the infection, remember neurosyphilis is reversible, Whipple's disease is reversible, protozoal disease is reversible. Thing which is not reversible among the dementia, HIV. HIV dementia is not reversible. Very, very important point for exam. Among psychiatric causes, depression, schizophrenia, and conversion disease, all of the three which presents with dementia 2 is also reversible. Among the rare causes, both sarcoidosis is also mentioned, vasculitis is also mentioned. And we know among infectious causes and non-infectious causes, autoimmune encephalitis is also a cause in which there is reversible dementia. Okay. So coming to the question, it says which of the following is the least common reversible cause of dementia? Now, you know, vitamin B12 deficiency is very much common in practice. You can see very commonly. Similarly, depression. Now, between B and C, both are rare cases, right? But we are currently we are currently also facing process of post-immune encephalitis stage 2. Regarding sarcoidosis, neurosarcoidosis itself, sarcoid being a rare disease, neurosarcoidosis is seen in less than 5 to 10% cases, less than 5 to 10% cases of sarcoid. And among which neurosarcoidosis is seen mostly present with lymphocytic meningitis or bilateral cerebral palsy, or it can be mimic multiple sclerosis. As a presentation of dementia in neuropsychology is more rare. Therefore, answer here will be among the given option will be sarcoidosis. Now, coming to the SCAM algorithm scoring. So, what is this confusion assessment method diagnostic algorithm? For delirium, we have to find which of the following is not true. Okay, so all of the following include all except. So, this is all except pattern question. Now, this SCAM score is a validated tool, right? It is a validated tool for assessment of delirium, particularly useful in ICU setting, given by the name CAM IC scoring. Okay, so it involves four feature mainly acute onset fluctuating course, inattention, disorganized thinking, and altered level of consciousness. When do you diagnose delirium? When there is feature 1 plus 2 present along with any one of 3 or 4. So either there is disorganized thinking or altered level of concentration, anyone present along with inattention or acute onset fluctuating course, you diagnose it to be delirium. Now, this option A, steady decline with subsequent onset, is nothing which is usually seen in delirium. Delirium is a rapid condition and it is not a subacute onset, it is very acute in onset, right? And there is no steady decline in it. So, where it is seen, steady decline of subacute onset, steady decline of subacute onset will be rather seen in dementia, but not in delirium. Therefore, option answer is option A. Okay, steady decline with subacute onset. Okay, so all of the following are alarm features of GID access. So, what is gestational reflux disorder? Usual presentation. Usual presentation are with heartburn or indigestion. There can be symptom of acid reflux too. Now, all GID doesn't need extensive evaluation, right? Because it doesn't make sense to only PPI trial is sometimes useful and beneficial for the treatment purpose. Now, what are the conditions when it asks for extensively evaluate the cases when there is presence of alarm symptom? What are those alarm symptoms? Let's break down each one by one. First of all, there is odynophagia. So why odynophagia is serious? Because if there is odynophagia, that is there is pain while deglutition, while swallowing, means there is some form of ulceration along with the food pipe. So there is risk of esophageal ulceration. That's why odynophagia is a risky symptom. Similarly, dysphagia, if there is inability of passage of food materials and there is difficulty in swallowing, means there is some chance of esophageal stricture formation. Right. That's why that is also alarming feature. What to do in such cases when there is odynophagia or dysphagia? In such cases, obviously, you need to go for upper GI endoscopy and look into the structure. Now, unexplained weight loss in a case of non-GID like presentation is something very much serious. If there is more than 5% weight loss in within 6 to 12 months, means for some reason nutrition supply is not available or something is eating up the nutrition. So either it is a malignancy versus stricture when there is decreased food intake. In both the cases, you need to go for endoscopy plus minus biopsy plus minus PET scan to look for the source, primary source, right? Now, why recurrent vomiting is also alarming feature? Recurrent vomiting becomes alarming feature because in such cases, you are suspecting the condition to be nothing but gastroparesis, as movement is getting delayed. In such cases, along with endoscopy, gastric emptying study can also be done. It also signifies it can be a case of echinacea cardia rather than GID. All right. So occult or gross GI bleed, obviously gross GI bleed at any case is alarming feature in whatever the condition is, but occult bleed. So how to point out occult bleed? Occult bleed you need to point out if a patient of GID, long-term GID presenting with anemia. Anemia which is iron deficiency anemia, or for some reason you have done stool occult blood test which comes out to be positive and there is GID like symptom, obviously you need to evaluate for it because there is risk of some case of ulceration, peptic ulcer diseases, okay, and esophagitis, severe erosive esophagitis or malignancy or something like Mallory USTI which is leading to such presentation of occult bleed. Okay, so what is the next step? If there is occult bleed, next step is go for esophagoduodenoscopy along with finding the source of bleed and taking biopsy or taking and making a ligation in the source of bleed. Right. Now jaundice. Jaundice, why it is alarm sign? Jaundice alarm sign means jaundice was something which is not supposed to be present in case of GID. Now GID presents with jaundice, GID plus jaundice, if it is the presentation, it means initial diagnosis of GID was nothing but wrong. It can be something to lead to liver diseases or hepatobiliary system, for which there was initial disparting, heartburn, acid reflux related symptoms. Right. Palpable mass or adenopathy, obviously, it signifies malignancy. What we are looking for, we are looking for Bartsch's node. What is Bartsch's node? It is left supraclavicular node. And what does it signify? It signifies GI tract cancer. Okay. Now, from a list of gastroesophageal malignancy, obviously all of those are important. So, what are the alarm signs? Alarm signs are odynophagia, dysphagia, unexplained white loss, recurrent vomiting, occult or gross GI bleed, jaundice, any mass palpable, or adenopathy like virtuous lymph node, or family history of malignancy. All of those were alarm signs. So, coming to the question, uh, not odynophagia alarm sign, recurrent vomiting alarm sign, significant white loss alarm sign, nocturnal symptom is not an alarm sign. It is rather the usual presentation because when people sleep in the night, due to the elimination of the gravity factor, this acid refluxes upward, resulting into increase in GID symptom at night. Therefore, among the behavioral therapy, it is often advised to use two pillows instead of one in case of GID management, or sleep with lying on the left side. That will decrease the chance of acid reflux related symptom in the night. Now coming to the next question, it says which of the following tissue is the most sensitive to ionizing radiation? Now, so here answer usually is lymphocyte, but I'll come to the point, right? Now, among the radiosensitive cell, lymphocyte or blood cell are the most radiosensitive cell. Like even a small dose of 0.5 to 1 grade of radiation can lead to apoptosis of severe lymphocytosis. And that is critical in something we call as acute radiation syndrome, which initially present with lymphocytopenia only. Right? Blood cells are the initial target of this manifestation. Now, what are the other organs that can also involve? Obviously, bone marrow can be involved, testis, or even the ovaries in female involved in ionizing radiation as well. Right? Intestinal epithelium involvement is also seen in case of ionizing radiation. Now, there is something of a concept of Barguin and Tribendo in the study of radiation therapy. They say that in a rapidly dividing cell, which is cell is dividing very frequently, for example, lymphocyte or intestinal cleft cell, they are the one which are the most radiosensitive. Or any undifferentiated cell, for example, hematopoietic stem cell are the one which are extensively radiosensitive. So, what are the one which are extensively radiosensitive? These are rapidly dividing cell or undifferentiated hematopoietic stem cell. All right. Okay. So you can see, as Harrison also mentioned, that bone is the most radio resistant. So most radio resistant is bone, then testis, where ovary, both are radio sensitive. Then also bone marrow and the sensitive organ. Organ which less need for cell renewal, such as heart, skeletal muscle, and nerve, are more resistant to immediate radiation effect. Right? Okay. So you can see with increase of radiation, mostly first there is involvement of hematopoietic stem cell, then there is GI structure, then CNS structure. Right? Okay. So among this, in small dosage, first thing that affects is decline in blood count. So decline in blood count is the first effect of radiation injury. Therefore, answer of our question will be lymphocyte. Should be lymphocyte. So, moving to next question. Which of the following hemolytic anemia? So, this will be the last question of this discussion of this first set. Obviously, I will discuss other question later in the next video. So, which of the following hemolytic anemia is most commonly associated with concurrent iron deficiency anemia? So, here, as you can see, all of those are hemolytic anemia. All right. Now, this hemolytic anemia can be divided based on the causes into inherited causes and acquired causes. Right. And again, it can be divided into intercorpuscular causes and extracorpuscular causes. PNH is something of a rare variety of disease which falls into the spectrum of intercorpuscular defect along with acquired disease. So PNH falls into this spectrum. Whereas Most of the hemoglobinopathies like hereditary spherocytosis or sickle cell anemia are inherited condition and intercorpuscular. Right? All right. Now, how and where there will be anemia presentation. Now, again, clinically for us, this anemia mainly of two types. This hemolytic anemia can be of mainly of two types, either intravascular hemolysis due to intravascular hemolysis or hemolysis taking in other organ, which we call by the name of extravascular hemolysis. When there is extravascular hemolysis in chronic stages, hepcidin will be suppressed. As hepcidin will be suppressed, there will be condition of increased iron overload and and increased iron overload because as there is no hepcidin to function, there is more absorption of iron from the gut and there is also no loss of iron from the body. Both of these factors result into state of increased iron overload state. Now, if this part is underlooked with time and iron chelator is not applied in such condition of extravascular hemolysis, chronic hemolysis, it may lead to secondary hemochromatosis and which may ultimately lead to cirrhosis or heart failure as a presentation, right? Because of hemochromatosis. Now, when there is intravascular hemolysis, invariably there is associated with hemoglobinuria. When there is hemoglobinuria, there is continuous loss of iron in the urine, which lead to secondary iron deficiency anemia. Clearly from it, you know, when hemolytic anemia presents with intravascular hemolysis or the type of hemolytic anemia which present with intravascular hemolysis, they will have secondary iron deficiency anemia. PNH is a condition which is nothing but chronic intravascular hemolysis took place, right? And there is a complement mediated destruction of the RBC, mainly taking in the blood vessel, and for which there is hemolysis releasing free hemoglobin, which is filtered by the kidney, leading to hemoglobin, right? And what is the classic manifestation of PNH? With PNH, we call it to be a dark cola colored urine. Why there is dark cola colored urine? Because because there is excretion of hemoglobin or hemoglobinuria per se in PNH, which results in the cola colored urine. So as there is hemoglobinuria, there is loss of iron from the body in urine, resulting into ultimately secondary iron deficiency. Okay. So these are the classification of hemolytic anemia into corpuscular defect and extracorpuscular, again inherited and acquired. Acquired intercorpuscular defect is PNH. All right. So if you look into the other causes like hereditary spherocytosis, there will be extravascular hemolysis. So iron is getting recycled here, not getting lost. In sickle cell anemia, there is also extravascular hemolysis, and in some stages, both of these conditions can lead to iron overload if iron chelators are not used in the treatment. Autoimmune hemolytic anemia, there is extravascular hemolysis going on in some other organ, for example, in case of in spleen or liver, which may result into organomegaly. So all of those conditions are nothing but case of extravascular hemolysis, mainly extravascular hemolysis. PNH is the one where there is intravascular hemolysis and hemoglobinuria. All right. Okay. So that's all discussion for today. And again, we'll make another session for its discussion of the remaining question.